Good morning, everyone. This is Cynthia Bauer from the Horowitz Center for Health Literacy, one of the co-sponsors of the Health Literacy in Action Conference. Please come in, take your virtual seat, get comfortable, get coffee, tea, water, snack, whatever you need to enjoy the next hour. We're going to have a very lively conversation about chronic disease prevention and health literacy. Okay. Well, as I said, welcome. I'm Cynthia Bauer, Director of the Horowitz Center for Health Literacy, which is part of the University of Maryland School of Public Health. We co-sponsor the Health Literacy in Action Conference with the Institute for Healthcare Advancement. Welcome back to day 2 of our virtual conference. We're very pleased to have you all with us today, and we're going to open Friday with a conversation about diabetes prevention culture from a health literacy lens. Before we turn to our panelists and their remarks and the discussion, I have a few housekeeping details to relay to you. First of all, if you're having any technical difficulties, please visit the virtual help desk on the conference homepage. You can receive continuing education credits for the conference. You must submit an overall conference evaluation to get your certificate. And the links to the evaluation will be going out this Friday afternoon after our closing session. Just so everyone is aware, we do record the presentations and they will be posted 2 weeks after the conference in the Health Literacy Solutions Center. So if you need to step away or you want to revisit this, they will be available to you. Everyone is muted during our panel discussion. At the end, there's a Q&A, but you can be putting your Q&A in the Q&A function all along. Please use the chat for introducing yourselves, commenting, carrying on the conversation during the session. But if you have questions for me or the panel, please put those in the Q&A portion. Let's see. One other thing is, if you haven't discovered this already, on the conference website, there is a virtual book club, and I would encourage you to visit that section, take a look at the recommendations that are already there and add your own. I know that, there's a lot of interesting books out there right now that are not specifically about health literacy, but definitely have health literacy implications. So please check out the virtual book club before the conference closes today. Okay, without further ado, let's turn to our panel today. I just want to make a few opening remarks before I turn it over to our first speaker, Pam Williams. The Center for Health Literacy has been working with all of the speakers represented on this panel today for about 1.5 years. We provide technical assistance through a contract with the Maryland Department of Health to support a lot of the work that you're here going to hear about today. And one of the things that I hope happens during the discussion and the Q&A is that we start making some headway on this conversation that we should be having about chronic disease prevention and health literacy, because many times we do important but very focused specific projects about one specific type of chronic disease prevention. But we know that health literacy as a way of thinking about health, approaching health, developing skills, that needs to be a lifelong endeavor, because no one knows when they might develop the symptoms of a chronic disease, and certainly many of the underlying behaviors to prevent chronic disease are quite similar. So health literacy has a lot to say about chronic disease prevention, and I hope we can use this panel today to help launch that broader conversation. So our first speaker today, who will set the stage and give us the big picture of diabetes prevention work here in the state of Maryland, is Pam Williams. She is the director of the Cancer and Chronic Disease Bureau within the Maryland Department of Health. Welcome, Pam, and we look forward to your remarks.
Thank you for the introduction. Next slide, please. During the fall of 2019, we created at Maryland Department of Health the Diabetes Action Plan, and this was developed by external stakeholders throughout Maryland and various departments at Maryland Department of Health. Since then, we have identified key diabetes focus areas to implement activities recommended from the Diabetes Action Plan. So this particular slide here includes a link to access the Maryland Diabetes Action Plan. And this plan is also available on Maryland Department of Health's website. We have developed partnerships with multiple stakeholders throughout the state. And one of the key areas that we identified as we were developing the Diabetes Action Plan was the area of health literacy. One of the things that we were able to identify when looking at the data, we saw that there were huge disparities among people with low health literacy rates and prevalence of diabetes. So with a lot of that information, that's when we started our work with a contract with the Horowitz Center. And we started with working with the local health departments and providing technical assistance around health literacy and also reviewing our website. So that was some of the first activities that we started in the fall of 2019. Next slide, please. Now I'm going to shift over into the statewide integrated health improvement strategy and just talk about some of the work we're doing with diabetes here. As a part of the total cost of care model, the state developed the statewide health improvement strategy. We call it the SIHIS measures. And it has several domains: hospital quality, care transformation goals, and total population health goals, focusing on 3 areas. One is the diabetes, opioids is the second, and maternal and child health is the third area. The diabetes population health goal is to reduce the mean BMI for adult Maryland residents. The prevalence of diabetes increases as the weight classification moves from healthy weight to overweight and obesity. And so that's where some of the decisions were made around having a target looking at BMI reduction. One thing that we do know is higher BMI correlates with increases in insulin resistance, which can produce higher levels of glucose. And that can result in prediabetes and diabetes. So that's why we wanted to focus in that area. Next slide, please. So as a part of the goal for reducing mean BMI, we have 3 milestones that we have been focusing on. So the first milestone is launching the Diabetes Prevention and Management Program track of the HSCRC Regional Partnership Catalyst Grant Program. And so this is with partnering with hospitals and community providers. And we've been making a lot of plans and working to increase the DPP enrollment throughout the state. The second milestone is to incorporate BMI measurement for all patients as a quality measure for all Maryland PCP practices. For patients who have an elevated BMI, they require documentation of a follow-up plan. And then the third milestone is expanding the CRIS referral tool to regional partnerships to increase referrals for diabetes prevention programs. So those are some of the activities that we have been working on at Maryland Department of Health in partnership with multiple stakeholders throughout the state. Thank you.
Great, thank you very much, Pam. Our next speaker then is Danielle Stahl, who is the Washington County Health Department Public Information Officer. For those of you who are not Maryland residents, Washington County is one of our counties up in the northwestern corner of the state that borders on several of our neighboring states. And Danielle's been a very active participant in the activities that Pam just outlined. So welcome, Danielle. We look forward to hearing what's going on in Washington County.
Great, thank you. Good morning, everyone. Like Cynthia said, I work for the Washington County Health Department. I wear several hats, but I'm also here today as our Local Health Improvement Coalition co-chair to kind of talk about our diabetes strategies as a coalition and as a county here in Maryland. Next slide. So for us, when the state came out with their diabetes action plan, as a health department, as an LHIC, and with our local hospital, we kind of came together to say, how do we incorporate diabetes strategies not just as a health institution, But how do we integrate our businesses, our local leadership, our whole community into our diabetes strategies? So one of our big things that we kind of focused on is actually here in October 2020, we launched a countywide health initiative called Go for Bold, which is focusing on losing 1 million community pounds by 2030. So we came up with this 10-year initiative that not only got, our community and our stakeholder involvement. Currently, we have over 40 health institutions, local businesses, and other partners here in our community who have signed up and pledged to lose pounds for our Go for Bold. And a big part of this is looking at every piece of integration. So really looking at the education piece for us was a big thing, and health literacy. Working in wellness and prevention for the health department for the last 6 years, we've kind of noticed here in Washington County, which is kind of rural, that there was this mind thinking of there is no pre-diabetes. Either I'm diabetic or I'm not, and my mom has diabetes, so I'm going to have diabetes. There was really this misunderstanding around prevention of diabetes and what pre-diabetes actually is and what it means. So for us, it was really connecting in this education piece and awareness around diabetes for our community. And that was not only through our messages, but really getting our PCP involvement and our providers here in the community to get on board with looking at A1Cs when their patients come into the office, talking to them about diabetes. And then actually we are in the process of working on a countywide referral system so that all of our referrals for diabetes, pre-diabetes, for evidence-based classes will all go to Meredith, which is our local hospital here in Washington County, so that we kind of have this hub so that we can increase our diabetes prevention classes, our living with diabetes management classes. And the other big thing too was to really kind of beef up our website for Healthy Washington County, which is our local health improvement coalition, and really making it a hub for health resources, specifically surrounding diabetes, hypertension, and other chronic conditions. Next slide. So as you can kind of see, this is some screenshots of our website, and we really kind of, for our Go for Bold, which is Do, Eat, Believe in a Healthy Washington County, is kind of our slogan, and it's really colorful out there, grabs attention, and we have these health resources on our page, and we have a specific page for prediabetes, diabetes prevention, and we really try to focus on making these very simple things that they could click into, that they could bring them into more resources, and having that connection. Next slide. So kind of what helped facilitate this idea and kind of where we wanted to start off with our diabetes strategies here in Washington County was we really had some great facilitators. We have a very active local health improvement coalition. So we were able, like I said, we were able to have over 40 partners just sign right up for our initiative. Everyone from, we were able to get PepsiCo on board, Shepherd Pratt, Middletown Valley Bank, Martin's, and a couple of other, like our Commission on Aging, our Chamber on Commerce signed up. So we really have all of these great facilitators and community champions who are really on board and have been able to help set this up within their businesses, their organizations, and really push out this message of Go for Bold and that link between weight loss and how that can affect, your diabetes status, your hypertension. It affects us, in an overweight situation. And so, but looking more into this, we were kind of noticing, we did have our biggest barriers were that lack of awareness of risk of diabetes, and people just not knowing what their risk is, and not understanding how you could be at risk for diabetes. So we really have pushed out, the pre-diabetes risk test. We have integrated it to a really simple thing on our website where you can go through and just click and it'll let you know if you're at risk. And then at the end, if you are at risk for diabetes, it actually automatically takes you to a page with all of our classes, all of our information. So we have found that, being able to bring all that information together in one hub would help with some of our barriers of getting people that knowledge. The referral system, not having that one place to go, and then not having enough lifestyle coaches to teach classes were kind of our barriers that we've been looking into and kind of seeing how we can best kind of get through these barriers. And some of them we have with working closely with the Horowitz Center, with being able to work with their technical assistants to create new flyers and materials and look at our website from fresh, new eyes to make sure that everything is within a reasonable health literacy standpoint for diabetes. That's the end of my slides.
Great. You guys are being so succinct. We're going to have plenty of time for discussion. Great. So our last speaker is Zach Rabowski, who is the Director of Practice Transformation for CareFirst Blue Cross Blue Shield. And he's going to talk to us a little bit about their work in diabetes prevention and with these local health improvement coalitions. And I know that we haven't said that much. So before we open the discussion, we'll say a little bit more about that just so everybody understands sort of that structure that everybody's been referring to. So Zach?
Yeah, thank you. And excited to be here today at the Health Literacy in Action Conference. So as Cynthia said, I lead our practice transformation and population health strategy at CareFirst. And obviously this topic today, diabetes and health literacy, is incredibly important to us. We have 3.4 million members in the Maryland, Northern Virginia, and DC area, but also nationally as well. And we see firsthand the struggles that our members face, as well as some of the struggles that our providers face in supporting prevention and teaching health literacy to their patients. So just to summarize this, the scope and size of diabetes, it actually costs CareFirst about $2.3 billion a year in healthcare costs and paid out for services related to diabetes and the complications of diabetes. So we are certainly committed to identifying and implementing the right solutions for prevention and diabetes management. But CareFirst is not just a health insurer. We're a healthcare transformation organization, and our mission is to ensure that our members have access to affordable care. And access is more than just having a large network or the dollars to pay for the services. It's ensuring that our members and our communities are delivered an experience that is focused on high quality and equitable care. And that's where health literacy comes into play. But before I get into that and kind of the details on how my team supports providers, I'm going to talk a little bit about what CareFirst is doing at large for diabetes prevention and management. So next slide, please. So we have a lot going on at CareFirst and a lot of different people and teams working on diabetes prevention and diabetes management, as well as health literacy. Specifically, we have our practice transformation team that is working at the healthcare provider level. That's my team. I'll talk a little bit more about that this morning. But we support providers through value-based contracts with alignment, specifically through the Maryland Primary Care Program, consulting support, robust data analytics. We're there to support practices in their day-to-day. We also have our member services and our care management team that work at the member or the patient level, and they're supporting diabetes prevention and diabetes management through benefit design, gaps in care reminders, nurse-led care plans. We have a lot of virtual disease management tools, and also how to get the right education out to the members to help them ultimately care for themselves. And then where there's overlap in terms of the provider community and the member community is our communities as a whole. And our community health and social impact team works on a lot of our community-led interventions at the larger population level, where we support the community through research, grant funding, community partnerships, our work specifically with the local health improvement coalitions, the LHICs, and also the local and state governments and SciHIS that Pam had discussed. So as I said, my work primarily with the healthcare providers, and I'll be speaking specifically about how my team works to support these initiatives. But as you can see, there is a ton of overlap, and we are always working together to make sure we are on the same page with our strategies. Next slide, please. So I think everyone who is joining us today understands the importance of health literacy. We know that not everyone speaks English. Only or about 52% of Maryland residents have less than a high school diploma. And further, even within minority groups, we see that there are reports of not receiving the same quality of care as other races or ethnicities, let alone the respect of the provider or the offices at which they visit. And we know that this adds a lot of cost to the healthcare system, which is ultimately paid for by the members. You combine this with the challenges of managing a chronic disease like diabetes, or even trying to prevent a chronic disease like diabetes, which requires coordination of medication, lifestyle changes, supplies, screening, specialist visits, jam-packed throughout the year. It's easy to see how this costs Maryland billions and billions of dollars. So this past year, at CareFirst, we really emphasized the importance of health literacy and also understanding how to deliver culturally competent communication. More than just making sure a patient receives instructions about what medications to take or what the proper diet is, but also ensuring that each patient's cultural norms, their health literacy, their past experiences, and other social determinants of health that impact prevention and treatment are considered. It's just simply not enough to tell a patient who's pre-diabetic to lose weight or to eat better and believe that that's going to work. It takes a lot more effort than that. So who does all this? And if you go to the next slide, please, talk a little bit about my team. So this is a heavy lift. And as I hinted at, it doesn't happen overnight. It doesn't happen without the proper support system. And fortunately at CareFirst, we're able to have a dedicated team to support healthcare providers in this mission. Our practice transformation team is made up of population health strategy consultants, otherwise known as practice consultants. If you participate in the PCMH program, I'm sure you know who we are. But these are master's prepared population health experts that have come to CareFirst with years of experience in various healthcare settings, and all have aligned with a strong desire to improve access to affordable, quality, and equitable care. And this team is working with our provider partners in our various value-based programs to help them implement interventions that improve outcomes and value. Next slide, please. So as I was hinting at, value is what we're aiming for. Quality improvement, better outcomes, that's how we define value. And by working with our independent practices and our health systems and our different partners throughout the state, we can help create a better experience for our members and ensure that they're receiving the most appropriate care. The way that we do that specifically on the practice transformation team is, one, we identify robust data and market, or we do robust data and market analysis using our data tools, sharing that with providers, identifying different opportunities. Second is building relationships between us and the provider community. We also try to build relationships within the healthcare system to help reduce some of that fragmentation, to make sure that there's communication between providers and health systems, and also state and local organizations that are trying to support something like diabetes prevention and management. And we also provide population health management support by recommending and supporting implementation of new workflows at the practice level or within the provider's office, with the goal of improving outcomes and getting better care for our members. Obviously, it's not easy, but we're committed to this type of behavior change and making sure that that our members are getting the healthcare experience that they deserve. Next slide. So the main program that we've done this through over the past decade or so is the Care First Patient-Centered Medical Home Program, or the PCMH program. This is our investment in primary care, which it's in its 11th year, or just wrapping up its 11th year. And we support over 4,400 primary care providers that are managing about $5.4 billion in total healthcare spend. Now, not all of that is diabetes, but as we mentioned earlier, a lot of it is diabetes, and diabetes is a huge focus point for us. Providers specifically participating in this program can earn a pretty substantial financial incentive by demonstrating savings and improvement in national quality measures. And we provide them with the population health tools to do that through the practice consultants, as well as the care coordination support with our nurse care managers who can work with individual patients who are most in need. And since 2011, we've saved about $1.4 billion compared to expected. And we'd love to continue, focusing on this program and helping with prevention and diabetes management. And as we do, it's crucial for us to also think about how do we, make sure that we're focusing on health literacy strategies and culturally competent care strategies as well. And I'll wrap up today with the next slide, just diving a bit deeper into how specifically we teach cultural competency and health literacy and ensure that that type of communication is happening. So this past year, we implemented a new cultural competency training requirement for our providers and value-based programs. This is a training through HHS Office of Minority Health, and it provides the fundamentals of culturally and linguistically appropriate services and offers resources and guidance to have an impactful conversation about health care and the appropriate care for patients from diverse cultures and backgrounds. Those who take this will learn the 5 constructs of culturally competent care: cultural awareness, cultural knowledge, cultural skills, cultural encounter, and cultural desire. But we're also making this a priority for our consultant team. We make sure that they're kept up to date on best practices and implementing health literacy and culturally competent communication strategies. We do implicit bias training. We are updating our data capabilities to help practices manage their population and also identify within their population opportunities to address health literacy and diabetes prevention as well. And then together, the practice consultants work with the primary care providers to assess where they're at in terms of their culturally and linguistically appropriate care service models. This might be implementing translation services or finding where they could get resources for translation services, how to pay extra attention to follow-up care and communication, and how, where, and when to provide educational materials for chronic diseases like diabetes or prevention of chronic diseases, and working on their cultural competent communication model. And finally, at the point of care, our care managers help our providers develop individualized care plans, carefully accounting for each individual's social determinants of health, their cultural norms, and their communication ability, and ultimately are acting as that additional support system for the patient and that liaison from the patient to the provider to make sure that the care that patient needs is being communicated to them in a way that best supports the patient or the member. So I must say that we're just beginning to scratch the surface on what's possible here when we connect health literacy interventions and culturally competent communication with our already existing best practices for diabetes and our programs for diabetes prevention. We do have a number of programs that I didn't get into in this presentation today, but regardless of the tool or the program that Care First is implementing or the partnership we're working with, we're always going to have that health literacy or cultural awareness focus moving forward, and will certainly be considered when we implement new strategies. And the team that's working with the providers will constantly be working on making sure that their practices are set up and they have the tools they need to do so as well at the point of care.
Great. Thank you so much, Zach. And again, thanks to all of our speakers for being so succinct in their remarks, so we have plenty of time for conversation. I want to do a little level setting though for those outside of Maryland, because there may be some things that were referred to that people are not familiar with. So Pam, I'm going to start with you. So there was this reference to local health improvement coalitions, or LHICs, right? All of you referred to these LHICs. Could you say a little bit more from the MDH perspective, from the Maryland Department of Health perspective, why, so these local health improvement coalitions were a creation of the state, right? The Maryland Department of Health asked each county to create these local health improvement coalitions a number of years ago, just for the benefit of people outside the state of Maryland, or even those within Maryland who don't know yet about their local health improvement coalition. Could you just say a little bit about why the state thought these local health improvement coalitions were such an important part of your community health work and your chronic disease prevention work?
Sure, absolutely. So within Maryland Department of Health, we do a lot of partnerships with the local health departments, and a lot of the grants that we do receive from CDC, we do that in partnership with the local health departments. Our thinking around this is that providing support and resources at the local level will help drive some of the activities that we want to have within those different jurisdictions statewide. So the creation of the local health improvement coalitions was a strategy that we are very much interested in, and we wanted to make sure that it's statewide, to make sure that there's activities and goals that are developed at that local level, so that we can carry out some of the interventions that we want to do statewide.
Great. And then the other term that was referred to that even people in the state might not know about are regional partnerships, right? So these regional partnerships are a creation by the state entity that regulates hospitals. It's referred to by its initials, HSCRC. So you might have heard that acronym in the presentations. So the HSCRC is the state agency that oversees hospitals in the state of Maryland. And they, in support of the diabetes prevention and chronic disease management work, had created what they called regional partnerships. So I don't know, Pam or Zach, do you want to say a little bit about those regional partnerships and how those kind of figure in your strategies as well?
I could take a stab at it, and
okay.
Zach, if you want to just fill in, that'll be fine.
Okay.
So HSCRC, so that's the Health Services Cost Review within the state. And so they invested approximately, I want to say about $80 million. And this is for what they call the Regional Partnership Catalyst Grant Program. And so this is for funding diabetes prevention programs in partnership with community providers. And so they've created 6 regional partnerships. So they've been developed and they're located statewide. So as I mentioned in the presentation, so they have one like in Western Maryland. They also have one Southern Maryland, Montgomery County, Baltimore City has a few. And I believe Prince George's might be the other one. So they're statewide and they're really aimed at developing these diabetes prevention programs, diabetes self-management education support programs in partnership with the community partners.
Right. Anybody want to add to that?
Sure. Yeah. So, I'll just add from, our perspective, the Care First is certainly making investments in these partnerships. But really what the benefit of this is an opportunity for us to align on goals and strategies. And, certainly for our team that's in the provider's office every day, it's very helpful to know that we're going in with a very similar message as other partners, other health systems, or even the state in terms of what we're trying to accomplish. So when we're all in it together and we can all visually see where we want to head, it makes our job easier to recommend those strategies and support the implementation of strategies to help get them there.
Okay. And maybe the last concept to introduce before we open the floor for the discussion, and I would say, even though I'd worked in public health a long time, I had not been working much on diabetes until we started doing this work with the state, was really the critical role of these NDPPs, right, as they're referred to, or the National Diabetes Prevention Programs, right? These are CDC vetted and sponsored programs, right? They're referred to as the evidence-based programs for diabetes prevention. So would one of you like to take a stab just for those who are uninitiated to the diabetes prevention program world, just take a stab at what the NDPP is, just so before we launch the open discussion.
I can give a quick overview.
Sure.
So the National Diabetes Prevention Program, like Cynthia said, is a CDC evidence-based program. It's a year-long program for people who are at risk for diabetes and who have a BMI of over 25. There's different methods. There's in-person, online, hybrid. And you have a lifestyle coach who goes through all of these different 26 lessons over a year. And the goal of the program is for each participant to lose 5 to 7% of their body weight, which has actually been proven to reduce their risk of diabetes. So it's a really great program. We have really been trying to vamp up our DPP program here in Washington County. We have 3 organizations who are providers, which is the health department, our local hospital, Meredith, and our Commission on Aging. So the 3 of us have really come together to talk about a county-wide referral system on getting providers to refer their patients to the program, and also just getting that information out into the community because people can sign up for the program. They don't have to be referred by their doctor.
Anybody want to add anything to that? Okay. Well, and a lot of that 80 million that Pam referred to from the, as part of the regional partnerships, a lot of that is going to expand this network of diabetes prevention programs. So it really is a core part of everybody's strategy, right? Is really, informing people of these programs and directing them towards these programs, because that's where the evidence has been, right? In terms of, effective programs. So I think that gives us some kind of baseline knowledge now for everybody who might not have been working in diabetes prevention before, just to kind of understand the landscape. So I think, you've given us a great overview of an organizational health literacy approach, right? Which is really what I was hoping people would get exposed to today, is thinking at this kind of broader policy and programmatic level. How do you kind of put together this package? And within that, there's going to be a variety of health literacy activities that then happen. So in our Q&A, we got an interesting question that I'd like to have the panelists all take a stab at. In one of our discussions yesterday, trust and building trust was a main topic. How do you build trust in communities to get people at risk for type 2 diabetes to participate in your programs? And I think, Danielle, to your point, to even be aware of the programs, right? So even prior to signing up there has to be that awareness, right? So could all of you take a stab then at this trust issue? Where does that factor in your strategies? And, is there anything specifically that you're doing now or would like to do on this trust building front?
Yeah, I mean, for us, working, like I said, we're working on a referral system, but we never really had a sound way to get referrals for people into our program. So a lot of our participants were word of mouth. And that's kind of where the trust comes in, is we have people who go through this program for a year. And hopefully, by the end of it, they're seeing these results. They're seeing the weight loss. They're seeing all these lifestyle changes that they've made. And then they're going out there and they're talking to their friends and they're talking to their family and they're helping us spread the word. So that's something that we do rely on a lot. Like, we take some time at the end of our classes to talk to all of our participants about, okay, here's what to do moving forward. How can you talk about other people to get them enlisted in? Because there's so many people out there with prediabetes who don't know it, and having that trust is really important. And I think that's too with your providers, which is where we have been working on the referral system. Is not only do you need the community out there saying, hey, there's these programs, they're great, but you need your doctor on your side saying, you do have prediabetes, you would benefit from this. And hey, look, you can go on our website and look at these testimonials for, your neighbor who completed the program, or, for so-and-so. So it's kind of bringing in those different components together to build trust.
Okay. Pam, did you want to add to that?
I would also like to add, and Danielle alluded to that about the provider, and just building that rapport with the providers and making sure that they're educating their patients. So that is one of our strategies as well. Trying to work more so with the providers and engaging the providers to understand, what are some of the barriers with educating their patients about prediabetes and referring to the diabetes prevention program and other lifestyle programs. So, so one of the activities we are doing now is creating a provider survey. So that's something that we're just trying to get a better understanding and seeing how we can support the providers so that they can also increase awareness with their patients.
And at Care First, I'd say we do so both directly and indirectly. So from a community perspective, we are certainly emphasizing with our members the partnerships we're building with names that they know and already trust. And I think that helps them to believe that Care First has their best interest in mind. Specifically at the patient level, our care managers and what we do with our care managers and the investment we make in their training to support their communication style with the patients to help them get through tough times, whether it's already managing diabetes or it's helping someone prevent the escalation of a chronic disease such as something from prediabetes to diabetes or another type. And then indirectly with providers, we are here to also support the provider community and make sure that they know how to continue building trust with patients as well. I think it's easy for any physician or any provider to say, oh, my patients trust me, I'm a great doctor, they've been seeing me for years. Sometimes they just don't listen to what I tell them. But when we sit down and actually look at some of the strategies and ways that we can dive deeper into their communication styles or how they work with different cultures, we can identify ways or tools that they can use to build better trust with their entire patient population, not just the majority or half of it.
Right. And there might be some kind of affirmation bias there, right, Zach? I mean, because the patients that these providers might be thinking about are the ones that probably are most agreeable, right? Are the ones
Absolutely.
who speak up and ask those questions, and not probably the majority of the patients who maybe don't show up as frequently or don't ask those questions or don't start those conversations.
Right. And I would venture to say that most of the time it's the conversation that just never takes place because you get a head nod or a patient that says, yeah, I understand. But when they leave the office and they think about it, they forgot to ask the 20 questions that they had because they felt rushed or they were intimidated by the pressure of being in the exam room. And they leave not knowing exactly what they need to do to best treat themselves.
Yeah. And I will just add that one of the things that Pam alluded to, in that first round of technical assistance, we actually did create a recorded training for providers about how to talk to patients about the NDPP as well as other programs, right? So we know that we can't assume that providers know how to initiate and have those conversations. And we also worked with a specific subset of counties in the state, same thing, talking points for providers about how to start and hold those conversations. So that is, again, an organizational health literacy strategy that everybody could, potentially incorporate into their own work. So we have a couple of questions in the Q&A that sort of relate to each other. And I should know this number, but I can't think of it right off the top of my head. But well, I'm sure one of you know, or maybe Anna Shao, our program coordinator, knows. What is the current dropout rate with the NDPP? And then as a corollary, what are any of you doing, or what do you know are the best practices for increasing people's retention in these programs and making them kind of sustainable over the long term? So there's been this reference to some of these grants, Care First is supporting these programs, but is there, how do, for example, in Washington County, how do you guys sustain your programs even when you're not getting this external financial support? So a couple of issues here. Dropout rate, how do you get people in and stay in, and how do you sustain the programs?
So as a health department, we get funding for this program, but it's not always the same amount, the same year. So we kind of do what we get. But for us, the dropout rate, we just started the class, we had 15 people signed up and 11 people showed up to the first class. So it kind of depends. I would say we have anywhere from maybe a 20 to 35% dropout rate. And those can be for many reasons. We find that in the beginning, if they aren't 100% ready to make those lifestyle changes and are just mentally and physically ready to do that, they tend to drop out, especially towards month 6, where we're no longer doing weekly classes. You go to biweekly and then monthly. So you're only meeting about once a month the last 6 months. So a lot of people, if they're not seeing the results, they tend to drop out. For us, for retention, it's a couple steps. It's in the beginning at intake of really taking time to talk deeper with these participants and kind of learn what is their motivation for joining this class. You know, are they ready to make these lifestyle changes, to go through a whole entire year of classes and support groups? So preparing them in the beginning to know what to expect. And then we do currently have a grant where we pay for up to $500 worth of lifestyle supports. And we have found that in the last year that we've had this grant and given it to participants, we've had 30 participants complete. And with that funding, what we did is in the beginning, we kind of gave them a welcome package. They got a scale, they got a Fitbit, they got a healthy cookbook, they got a blood pressure monitor cuff, and that was kind of their starter kit. And then what we did is by month 5 or 6, we said, you have like $250 left. What do you feel like you need? You know, what do you feel like you need to succeed in this class? Is it a treadmill? Is it a new pair of sneakers? Is it a food scale? Letting each participant kind of decide what do they feel like they need in order to reach their goals. So we even did gym memberships for some. So we found that was really helpful, and the feedback we got from our participants was having to be able to choose what would help them for their success. It kind of gave them a revitalization in the program, that it was like, we've been doing this for 5 months, now I get to look forward to like these little things that I got to pick out that I'm gonna like use. So we found some really great success in that. But we always try to go for at least probably 15 to 25 participants in each class, knowing there's going to be drop-offs at the beginning, there's probably going to be some drop-offs at 6 months. It's just one thing that we have constantly saying is there's always a couple in there that will always drop.
Pam or Zach, do you want to add to that about just in terms of, you know, identifying those things that will really help people both sign up but also stay in the program, and then any kind of financial sustainability questions?
The only thing I would like to add is right now we are internally looking at DPP enrollment, seeing how we can increase and maintain DPP enrollment, just looking statewide, looking at the data. So we're still trying to come up, identify what our strategies are going to be around that right now.
Yeah. I will say also, I mean, the NDPP is one of the best research programs out there. There's a pretty big literature on that. So for those of you who are interested in that, you know, the CDC does have a lot of information on its website about that, a lot of resources. So that is a place that you can also kind of follow up. We have a lot of questions coming into the Q&A now. So next question in the queue was, are the state medical associations and the state nurses association aligned with what you're all talking about? And do they have value-added initiatives as well? So I don't know, Zach or Pam, maybe you're better positioned to answer that about the state medical association and the state nurses association. Where do they fit in this strategy?
So we have been working with the American Medical Association. So they do have a pre-diabetes strategy where they've been providing training modules, and they also have been working with particular provider organizations around training and technical assistance. So we have been working with the American Medical Association to see how we can align our efforts and partner together with some of those activities. We've also, we also have been working with MedChi as well.
MedChi is the state medical association.
Yeah. So we've been working with them.
Yeah, we have some partnerships with MedChi as well, and consistently and are constantly communicating. I wish I knew more about some of the other associations, but I know that those conversations are happening, and we're doing our best to align on goals and messaging.
Okay, great. So our next question comes from Dewan Patterson, who was our opening conference speaker yesterday, and he does a lot of work at the community level in Baltimore. And his question was, throughout today's discussion, there's a heavy investment in providers' professional development and incentives for the providers. What are some examples of investments for community residents who act as trusted messengers for your programs and interventions?
So we have created at Maryland Department of Health a patient and family caregiver advisory board for diabetes. So there are 15 members of this advisory board. And so they have been advising us and working with us on, we have created a diabetes quality task force. And so as a part of this group, they've been working with us on providing recommendations on what activities we need to work on at Maryland Department of Health. This advisory group is also planning a virtual webinar or training forum. So this is being planned for 2022, so like in February. And so they're working on planning this right now. And this is something, the goal is for this to be a statewide virtual forum.
So Danielle, your $500 per participant seems to me to potentially qualify as a community investment. I mean, it's for the individual participants, but to Dewan's point, it's providing resources to people in the community to help address any barriers they might have or help them be more successful. Are you aware of many other DPPs who take that approach, that are giving that kind of pot of resources and, letting people sort of pick and choose what will help them the most? Oh, you're still on mute. Danielle, you're still on mute.
Hear me okay?
Yeah.
So for us, I mean, that was a specific grant that we received from the Maryland Department of Health to provide that 500. But even before that, I mean, we tried to always assess barriers, whether that was technology, transportation, childcare, and then we would just use our own personal funds from the health department to be able to address those barriers if, we needed funds to do that. But from that grant, we have found that, having that set money and letting them choose has been really beneficial for their experience in the program and for retention. And just kind of going back off into, the investment for the community is, and how do we, there's a couple other questions in there, how do we continue to get these people to make healthy lifestyle changes after the program ends? How do you keep off the weight? That's kind of where we're also tying in our initiative, Go for Bold. It's actually, there's a whole weight tracker where people can go in and track their weight, and that gets put into a big community pot of pounds lost. So we're really trying to, focus on that for all of our DPP completers, that they can use this weight tracker to hold themselves accountable, essentially, by logging their weight, just like they do in the program, and kind of bringing this back to, these are community pounds. These are not individual pounds. We're not, that as a community, if we lose these pounds, look at all of the great advantages, not for just you personally or the business, but for a community whole. If we can reach this goal of 1 million pounds in 10 years, what's our community going to look like then? Where are our our diabetes rates going to be there in the county? Where are our hospitalizations, for diabetes complications? And just overall. So we try to really tie back into like, this is a community initiative that, we have community champions who have gone and lost weight and who have reached out to us and said, how can I get involved? How can I help spread the word? And that's what, we're trying to bring in is just this sense of community that we're all in this together. It's not about your pounds lost or your pounds lost, but the community's pounds lost.
Zach, anything you want to say about the community investment from the Blue Cross perspective?
Yeah, so as I mentioned early on in my presentation, we have our social, our community health and social impact team who is dedicated to this type of work. And at the moment or in the near future, I don't know the specific dates, but I know there will be an RFP process to really encourage a community-driven approach and provide funding to these types of organizations within the community, really focused on impacting social determinants of health from a community-led standpoint and interventions that happen outside of the hospital or outside of the doctor's office. So as I said, I don't know exactly where we're at in that process, but it continues to be an investment we're making both in strategy and in funding the types of interventions that I think Pam and Danielle have spoke about today as well.
And I will put in a plug for something that we're doing that also part of involves Danielle, again, I said that I was pretty new to these programs, even though I'd worked at CDC and had worked on health literacy for a long time. I had not been focused on diabetes. And my first look at the NDPP was, wow, this is a really individually focused program, even though eating is such a communal behavior, right? So where are all the other people in the lives of the people we're trying to encourage to lose weight? So we have partnered with a nonprofit to do, we undertook one project to look at intentionally enrolling people as a pair. So right now, the way the NDPP is set up is you enroll as an individual, but we could put it, with FHI 360 is our partner on that project. They are the lead and we're a subcontractor to them. And the idea had been, what happens when you enroll people as a pair? Unfortunately, we had this idea right around the time the pandemic hit. So it didn't work quite how we had hoped. But, I recall when I used to be in my office all the time, is I had, a couple of people that I always ate lunch with, right? So that influenced my food choices right there, because we were always deciding, were we bringing our lunch? Were we going out? You live with other people maybe, or you go shopping with a neighbor or somebody who relies on somebody else for transportation. They're kind of dependent on their choices about where they go food shopping and things. So we really wanted to look at what happens when you enroll people as a pair. And then interestingly, the Federal Office of Minority Health kind of upped the game even more and said, what happens when you look at families? So they recently had an RFP out for looking at family approaches to diabetes prevention and diabetes management. So we're also going to be looking at some family approaches through that process as well. So I think stay tuned. I think there's, probably some evolution that will happen in thinking about these programs from a more collective perspective. So we have a couple of questions about what happens when people finish the program. So do any of you want to speak to that? Because obviously, 12 months, that's a long time, but once people complete it, they still have the rest of their lives. So what are the things that you've seen that are maybe some of the either health literacy challenges once people finish, and sort of how are you addressing that? Or how could health literacy strategies help people keep the weight loss off?
So for us, we currently don't follow up with them once they've completed. Also, they can take the class multiple times. I have one participant, this is her third class, just because she likes the accountability and she likes having the support group. She has the knowledge, she knows the lessons, but she likes having that group to talk to. She likes having the accountability, a lifestyle coach. So we encourage people that if they can take the class as many times as they like. But in our Go for Bold project, you know, that is something that we were thinking about, is looking into the future. This is a 10-year initiative. How do we track this? How are we looking at our participants that are completing DPP and losing all this weight? How do we get them to continue to track those pounds? So part of what we're going to be integrating is into our DPP classes is to have each participant sign up on our Go for Bold weight tracker. And that way they can continue to track that. It's not so much for us. We won't be able to track individuals, but they can track it. And having that website with resources is something too that we present to them, knowing that, okay, this class has ended, but here's where you can go to get additional resources on nutrition, physical activity, mental health. All of that is things that we talk about in DPP. So for us, it's really referring people back to Healthy Washington County, which again is our local health improvement coalition. It's our website. It is our source of all the health resources in the county, state, you know, stuff from CDC. So we have an abundance of information located in one central hub that we refer people to.
Great. Thank you very much. And I just got a time check that actually we're wrapping at 11:45 today. I thought we were wrapping at noon. So there are a couple more questions we didn't get to. So apologies for that, but thank you all. Thank you to our panelists for some really great information about these organizational health literacy approaches that you're all pursuing. Thank you for all the great Q&A, and yes, enjoy the rest of the conference. Thank you all so much.